Okay, I'm back. This is reperfusion injury. Okay, so we have a patient that came in with a late anterior STEMI. Why did I say late? Because you have already Qs here, B2, Q waves, ST with Q waves, ST with Q waves, B2, B3, 4, 5, and 6. Okay, this is a late presentation anterior STEMI. So the patient went to the cath lab. The interventionalist did an angiogram, and this is what they saw in the cath lab. So we have a 3-vessel disease. So the RCA, 90% is occluded proximally. Medially is 50%, and medial to the going distal is 80%, and far distal is 60%, and the PDA is 80%. Okay, so the left main is blocked. They put 1 stent. The LAD is blocked, 3 stents. The diagonal one is blocked, 1 stent. So we have a total of 1, 3 in 1, total of 5 stents. Okay. So now, the cert, we have here 40%, almost probably proximal, going medial. And obtuse marginal, 40%. The OM1, and the OM2 has 70%. Okay, so this is the ECG before procedure. Late presentation because we have already Q waves. If it is a fresh STEMI, we should not be getting this. It should be maybe very small one, but not this one. It's almost deep. So I should say this is probably hours old, maybe 3 hours old, 2 to 3 hours old STEMI. Okay, the procedure is finished. Stent is inserted to the left main, LAD into the diagonal. So when stents were put in, they open up the coronary artery, but there is a problem distally. There's no distal blood flow because the TIMI flow is less than 3. Okay, so that's a problem. So if there are clots, they will do thrombectomy. If there are plaques, they will do rotablation. And they will also give intracoronary nipride or nitroprusside injection. They will do everything they could there. Okay, so somehow the patient continues to have a TIMI flow of less than 3, and there's no distal flow. But anyway, the patient came to the unit, and they say the TIMI flow is less than 3. So post-PCI, this is the ECG. The V1 here, we don't have an ST elevation, but we do have here. And the same B2, B3, 4, 5, and 6 are all with ST elevation. That is 1 to 2 hours after PCI. After 12 hours, the same. There are no changes. It's still with ST elevation. After 18 hours, the same. ST elevation. And one good thing, the patient was not in distress. Okay? And here, after a day or 2, the patient was responding slowly. And we notice now that the STs are coming down. Okay? But we have deeper cues. So the cues tells us about infarcted cells. The ST, these are the tissues that are actually vulnerable to dying or living. So the STs tells us that we can save these cells. They are injured cells. So if we act quick, or the patient came in earlier, we will be able to save most of the cells that are injured. But if they will come late, then that's a problem. Okay, so the patient came probably 2-3 hours old STEMI. Okay, so we have a reperfusion injury because the TIMI flow is less than 3. And we open up the arteries here, but there's no distal flow. So TIMI flow is less than 3. But luckily, after a day or 2, the patient responded, and we have now STs coming down. The Qs are deep, and the Qs are the infarcted cells, and the injured cells are going to be safe. Okay, so usually, whether reperfusion injury or reperfusion, okay, we start their medications. Okay, so they will get once a day of enteric aspirin, ticagrelor or Plavix, beta blocker if the heart rate is above 50 and blood pressure is more than 90, and ACE inhibitors, and statin. So the complications that we will avoid with these patients is to see that there's no thrombosis. So that's the action of the aspirin and the antiplatelets. And we don't want remodeling. We don't want failure, heart failure here. So we're gonna be starting the beta blocker. That is a negative inotropy, reducing the heart's demand, and ACE inhibitor. Actually, that is reducing the afterload. Okay, so again, continue to monitor the patient as usual. Now, reperfusion here, this reperfusion rhythm here from slow VTAC to VTAC, they're actually caused by automaticity. So this one, all you have to do is check that the lights are okay, the patient's lungs are clear and they're not in failure, okay, and they're not blocking their stents. Okay, so continuous assessment of the patient. Okay, so the advice, if they have problems, the best thing they can do, these people, these patients complain some discomfort, whether it is toothache, chest pain, numbness or anything, go to the hospital right away because time counts. The muscle, you know, is to be saved. So the earlier you come to the hospital, the earlier you PCI, the better the survival of the injured tissue. Okay, and we reduce the infarcted site. Okay, so you see here, again, the reperfusion here, these are caused by automaticity, not re-entry. And here, we got also VTAC, slow VTAC here. But again, we don't have yet a reperfusion here. So keep an eye again, lights and everything has to be checked, as I said. Full assessment, avoid failure, avoid restenosis, okay? And keep an eye on those arrhythmias. Okay, so our next video soon will be about, you know, what you call this one, kidney failure. I'll be talking about dialysis and the transplant. Okay, thank you so much.